Humans derive the energy required to survive from the oxidative breakdown of molecules consumed in food. This is called cellular respiration, and all cells in the body require a continuous supply of oxygen to facilitate this process. The principal purpose of the respiratory system is to ensure that oxygen enters the body and carbon dioxide, a waste product of cellular respiration, is removed. This function is carried out by two main processes: ventilation, breathing, the movement of air in and out of the lungs; gaseous exchange, the exchange of oxygen and carbon dioxide with the circulatory system. Breathing, also known as ventilation, is a combination of active and passive processes to move air in and out of the lungs, referred to as inspiration and expiration. The movement of air is a result of alterations to the air pressure in the thoracic cavity created by the diaphragm, intercostal muscles, and rib cage. The diaphragm is a sheet of muscles that sits beneath the lungs and separates the thorax from the abdomen. In its relaxed state, it is an arc, but in the active phase of the ventilation, it contracts and moves downwards. At the same time, the external intercostal muscles that connect between the ribs also contract. This causes the rib cage to be pulled up and out. The combined result is an increase in the volume of the thoracic cavity and a reduction in the air pressure within the lungs to below that of the atmospheric pressure. This allows air to flow in, filling the lungs. Within the second or passive phase, the diaphragm and external intercostal muscles both relax. As the diaphragm returns to its arc shape and the rib cage moves down and in, the pressure within the lungs becomes higher than the atmospheric pressure, allowing air to flow out. Inspiration starts at the nose and mouth, where air enters our body. It first passes through the sinuses that are hollow spaces in the nose. Here, the air is filtered of dust and dirt, warmed and moistened. It then continues down the respiratory tract to the pharynx and larynx, also known as the throat and voice box. The air makes its way through this funnel before entering the trachea, a tube consisting of connective tissue and smooth muscle, which is the main airway to the lungs. Incomplete rings of cartilage protect the trachea and ensure it always remains open as the pressure changes with the body. Towards the bottom of the trachea, it splits into the right and left bronchus or bronchi, the primary routes into the lungs. The lungs differ in size and structure. The right lung has 3 lobes, whereas the left has only 2. The left is also slightly smaller, with a cardiac notch to allow space for the heart. Inside the lungs, each of the bronchi split into secondary, then tertiary bronchi, before branching further into smaller tubes called bronchioles. To prevent any remaining harmful particles or microorganisms reaching the lungs, the trachea and the maze of bronchi is kept clean with the help of mucus and cilia cells. The mucus captures any remaining harmful particles or pathogens and is then swept back to the throat by cilia, where it is coughed or sneezed out or swallowed. The bronchioles lead to tiny air sacs, known as alveoli, small balls with a thin, moist membrane only 1 cell thick. It is here that the diffusion of gases occurs. There are about 300 million alveoli present in the lungs, with a total cross-sectional area of 50 to 70 square meters. The alveoli are surrounded by blood capillaries that will transfer oxygen away from the lungs to those cells that need it, and also bring back the waste CO2 to be exhaled. Oxygen molecules enter the bloodstream by diffusing across the layers of epithelial and endothelial cells. Here they attach to the hemoglobin in the red blood cells before being carried off around the body. At the same time, waste CO2 diffuses in the other direction, back into the alveoli, ready to be expelled through exhalation. Asthma is a chronic condition where inflammation causes intermittent narrowing of the bronchial tubes. The characteristics of asthma are inflammation of the airways and bronchial hyporesponsiveness. This results in symptoms that include shortness of breath, coughing, wheezing, and chest tightness. During an asthma attack, the airways become narrowed as muscles in the walls of the airway tighten and the lining of the airway becomes inflamed as a reaction to environmental stimuli such as allergens, cold air, respiratory infections, or exercise. As a response to an irritant, the postganglionic neurons of the afferent vagus nerve, parasympathetic nervous system, release the neurotransmitter acetylcholine. This, in turn, triggers contraction of smooth muscle in the bronchioles. This decreases the volume of the tubes and reduces airflow, leading to shortness of breath. Mucus hypersecretion also contributes to the airflow obstruction. COPD is an umbrella term for people with chronic bronchitis, the presence of cough and sputum production for at least 3 months in each of 2 consecutive years, emphysema, destruction of the gas-exchanging surfaces of the lung, the alveoli, or both. COPD is a common, preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation. COPD is characterized by increasing breathlessness, a persistent chesty cough, and wheezing. COPD is the result of long-term cumulative exposure to noxious gases and particles. Worldwide, the most commonly encountered risk factor for COPD is tobacco smoking. Outdoor, occupational, and indoor air pollution, the latter resulting from the burning of biomass fuels, are other major COPD risk factors. In a healthy lung, the airways are kept open because the elastic lung tissue helps to maintain their shape. In patients with COPD, the airways narrow because lung tissue is damaged and pulls less on the airways. The walls themselves collapse in due to a loss of elasticity. Inflammation reduces the space within the tubes. COPD exacerbations are defined as an acute worsening of respiratory systems that result in additional therapy. They are classified as mild, treated with short-acting bronchodilators only, SABDs; moderate, treated with SABDs plus antibiotics and/or oral corticosteroids; or severe. Patient requires hospitalization or visits the emergency room. Severe exacerbations may also be associated with acute respiratory failure. Triggers can be infection from bacteria, viruses, or environmental pollutants such as smoke or dust. Acute exacerbations have been shown to lead to a long-term decline in lung function.